Good afternoon, everyone. I would like to take this opportunity to thanks APSO, Dr. Sushmita Bhatnagar ma'am and Basant sir for giving me an opportunity to participate in this debate. The speakers which have spoken for thought has really motivated me to go into the depths of research and reading to do my best to come up with very good genetic testing modalities at very cheap rate to make it available to have to create equity of access for everyone. But what is more important is we need not to do everything what we can do is best, but what we have to do is what is needed. So it is obviously very important for prognostication. It should be done. It is required, but it should not be made mandatory in every children with cancer. So it should not be mandatory. So why genetic testing is necessary? It is already being discussed and being told in detail by the four speakers. But where are we today at this point of time with genetic testing? As per this paper, in an international consensus or minimally preclinical testing requirements, whatever the anti-cancer drugs, the therapeutic part after doing genetic testing have been made available are based upon the drugs which have adult indications. So in which they have not studied, they have not given importance to the microbiological or biological relevance to the childhood cancer. And as Sir Samir Bakshi sir has told that there is a tumor microenvironment, which is also very, very important thing to be taken into consideration while deciding whether the drug which is being used or the target which is being taken into consideration in adults has equal response, will have equal response to be used, suitable to be used in children. I will give examples in coming slides. So in children and adults, even if the mutation is same, but the genomic variations, structural variations are quite different. So the studies which have been quoted are basically based as adult based. We have to start first the research work, then we have to make it mandatory to be used in clinical settings. So new therapeutic, whatever the drugs like ALK inhibitors, crizotinib, these drugs lack dosage guidelines for children. So an act was passed by FDA that whatever the drugs, 63 drugs were available to be used, which have same mechanism of action and can be used in children with cancer, which we have identified the genes for. Out of those, only 3 drugs in detail they have given the regulations can be used in children. So when we don't have any treatment to offer to those children, why to subject every child with tumor or cancer to genetic testing? So as per this slide, we can see that in neuroblastomas, as four speakers have spoken, that ALK mutation, we can use targeted therapies like crizotinib and lorlatinib, but still this slide highlights that all maximum of the drugs which can be used are under clinical trials. So first, till the phase 4 trials are finished for all of these drugs, and we have the data in hand that we can offer something to these patients, then only we should subject these children to genetic testing. There is no point in peeping everyone's genetics and opening a Pandora box to come up with the information for which we need not know what to do in the future. So available therapies like just to review, for neuroblastomas, as we can say that ALK inhibitors, crizotinib is available. It has been shown in papers to have variable efficacies. It is having no adequate response being seen in any of the paper if being used as monotherapy. So if we have to use it with along with other chemotherapy drugs, we have to do research first and then make the tests mandatory. And one drug like Sir has told that already we have clinical trials moved ahead is anti-GD2 monoclonal antibodies like immune checkpoint mediators we can use, but all those drugs are under surveillance. The CAR T therapy, which four speakers have spoken, is also under trial in neuroblastomas and Wilms tumor. So while seeing everything research going on all around the world and running behind the genetic testing, we should not miss the point of making the life and survival or better for these children. Outcome should improve by those things. So when we do genetic testing and we subject a child to next generation sequencing, do we have an expertise to integrate and read all the results? Reading the results of genetic tests is very complicated. Being a surgeon, to read this much what I have read has taken a lot of time, but to just read a single genetic report of a next generation sequencing is very difficult. Even if they have done this and have integrated with histopathologists, more than 80% of the children do not participate in those trials or cannot take those therapies because of poor performance status, because of already having been improvement in the course of the treatment, and they lack insurance facilities to take those drugs. When the cost of those drugs and treatments and even the genetic testing starts from 35,000, 20,000 and going up to lakhs and lakhs of rupees, when they barely could manage the completion of the treatment from starting of investigations in tumor board, we have seen that we were using investigations every 3 months, 6 months, but it is possible to do based upon the public, but it is costly. We can feel that might be patient is not paying, but someone is paying for all those investigations. So are we ready to just do genetic testing in all the children with cancer? Absolutely not. This is a very beautiful article being published in Lancet in year 2023, which gives sort of an assessment of childhood cancer services in India. What are the gaps and challenges? So we have to first meet the basic challenges before just straight away, based upon the research going in West, to just peep into the genetic testing for all. This study included 137 tertiary care hospitals, 92 secondary level hospitals across 26 states and 4 union territories. 80% of the children they have found in comparison to other countries are residing in the low and middle income countries with no specific program or policies available for childhood cancers. So this table I wanted to highlight this, that the basic facilities like availability of pediatric oncologists in a public hospital is in 48% of the hospitals. So it is and pediatric oncosurgeon availability is just in 14% of the hospitals. So genetic testing can help, but we should first meet with the basic minimum requirement being available. The availability of the childhood cancer treating drugs, this graph specifically shows that in public hospitals, the availability of the drug in stock is less than 50% in all the public hospitals. And especially the targeted therapies, the availability is 30 to 35% of the hospitals. So when the availability of basic drugs, like which we give for Wilms tumor, neuroblastomas, is very less. So making it available making available the genetic testing to everyone is a not wise thing to believe in. This shows that the cancer treating medicines are free of cost availability is only in 30 to 40% of the public hospitals in India. So basic drugs like cyclophosphamide, doxorubicin, cytarabine, whatever these drugs are available, this pink color shows that the stock is that this is in stock, rest green is that not available. So we can say that basic drugs are also not available in many public hospitals in India. The facilities to give to provide the immunotherapy, chemotherapies, mixing room with vents, biosafety cabinets for making those drugs, radiotherapy setups is available in less than 70% of the public and NGO charitable hospitals across India. So less than 10% of the tertiary hospitals had provision for training courses in pediatric oncology and pediatric surgical oncology. Availability of pediatric oncologists as compared to West, which they have been doing in quite a bit research, is like in Ukraine is highest, is 1:4, compared to that in low and middle income countries is 1:750. The mortality ratio to incidence ratio for childhood cancer ranges from 17 to 72% in India. So this range is a bit of worry. This range shows that there is non-equity of access, non-equity of services being provided across India. In metropolitan cities, the availability of services may be good. We can afford, some patients, most of the patients can afford to subject their children to genetic testing and all those things, but basic in peripheries where they have to come to metropolitan cities to access the basic treatment of surgery, chemotherapy, it is quite a bit for those parents and children. So to get good outcome, good outcome in pediatric cancer, we should shift our focus from survival to thriving first, and then proceed further. The focus should be currently on dedicated pediatric oncology and oncosurgery units with supportive and hospice care. Availability of drugs should be made, and there should be national childhood cancer policies being made to provide better services to children. So this paper, beautiful paper, shows that the treatment abandonment rate in India is 10% to 60%. This is also a range. So the range is always a worry for me. So this shows that when a parent comes to us with a child having a mass in the abdomen, supposedly Wilms tumor, to convince them that this is the course of the treatment, this will be the prognosis, this is the treatment requirement, what we want from you to do. We cannot just explain them, because the treatment abandonment rate is quite large in India. So we have to work on counseling part as such. Just doing research in genetic testing, making it available. But do we understand? We can understand by reading 1,000 times even the genetic testing and the significance of that. But do the parents understand? I don't think so that a parent coming to us in our hospital, it takes a lot of time to even explain to them the surgical procedure being required for perforation. They ask multiple questions. Why is anything like you can get away with doing just medicine part, no need of surgery? So we need genetic counseling in India. The part of the importance of genetic counseling is like genetic counselor is like an air conditioner in this room. When in earlier times we have open windows and all those things, we can feel that we might not need them. But when we have them on board in a tumor board, we have genetic counselors, we will not be able to live without them. We cannot be able to run if the genetic testing, we have to move forward with genetic testing. So in India, we have the trained genetic counselors per million population is at the bottom. So we have to work on that part first before making genetic testing mandatory. So every patient remembers that how I felt, but he or she might not remember the gene. It is the experience the family perceives during the treatment, which makes them not to have lost to follow up. It is that important. The counseling part is that important. So quality of, and before doing genetic testing, we should focus more on like Beckwith-Wiedemann syndrome, which was the example being given by the 4 speakers. 70% of the patients with children with Beckwith-Wiedemann syndrome will have macroglosia, these hypertrophic syndromes like lateralized hypertrophic syndromes. We have to focus on those things rather than spending everything on tools. We should work on skills to pick those patients first and then do genetic testing to guide them what the prognosis, not by picking an hepatoblastoma and doing genetic testing to find out whether the child has Beckwith-Wiedemann syndrome or not. Because the risk of child with Beckwith-Wiedemann syndrome to have hepatoblastoma is less than 5%. It is higher, but the percentage of the patients with hepatoblastoma having Beckwith-Wiedemann syndrome is less than 5%. And the quality of history taking is, this paper clearly shows that the family history taken by genetic counselor is quite significantly better than compared to surgeons and oncologists. So the next concept which comes is of the consent. Before doing any genetic test, any surgery, we need to take consent, which should be clear, coherent, and the willing part is very important. It should be ongoing. With the literacy rate of less than 70%, that is also the census of 2011. When we don't expect our parents to just understand the criticality of follow-up every 3 months after the surgery, after the completion of the treatment, how can we believe that they will be able to understand the wide criticality of genetic counseling, the genetic testing which they will be subjecting their child to? So pre and post testing counseling is very important. And for these things, we need genetic counselors as a part of the tumor board. So ethical, legal, and there are other issues like genetic testing, ethical, legal, and psychological issues. With by subjecting in the minor patients, it is the parents who give the consent. But by taking that part of the consent, the child is losing his autonomy, and the cost is quite high. And equity of access, as I told, is not everywhere. So we have to make it available. Plus, when we do a genetic testing, supposedly a child is subjected to a genetic test, like if he feels, we have to tell that the risk that supposedly RET proto-oncogene mutation, the risk of MEN2 is quite high. We have to tell the family members of that child to be in follow-up. But if the child doesn't want if the parent doesn't want every family member to know about this thing because this can create, and with all those ethical and legal concerns, this will create social discrimination, stigma, like the child will be estranged from the family, might not be given equal educational or other occupational facilities being given to the other children in the family. So we should work on tool. This paper clearly shows that there are cancer predisposition syndromes being available. We have to first see the clinical symptoms, work on our skills, and if there is an indication to do the genetic testing in those children only, we should subject the child to genetic testing. Like there is a criteria named as Jongman's criteria, which have certain, like in Wilms tumor, if the tumor is bilateral, if it is quite early in the age group, and if there is bilateral nephrogenic rests on MRI, if there is multicentric tumor, then we can think of doing genetic testing in this, useful in Wilms tumor, not in everyone. This is the childhood cancer indication for referral, when we should refer a child to genetics. They have mainly been focused on the clinical features. These are the patient characteristics which are suggestive of hereditary pediatric cancers. So if these characteristics are seen in the patients, then only we should subject the child to genetic cancer. So it should be done if malignant disease can develop in childhood, not when we expect the child will develop the malignancy in adulthood. As per American Society of Human Genetic Guidelines, we should defer this practice, and evidence of risk reduction should exist, which exists in few of the oncogenic mutation, knowing like retinoblastomas, RET proto-oncogene mutation for MEN2 and MEN2B, and APC for familial adenomatous polyposis. This is just to quote examples. And we should work in the child's best interest. We should try for most good and least harm comes to all. So this is the concluding. Thank you.